afternoon. Thank you for joining us. I'm going to get started for the interest of time by introducing Dr. Azani and Dr. Deepan Punirsavam here in just a minute. We're happy to have Dr. Azani here with us this afternoon, kind of sharing quite a bit of his research. He's been instrumental in training multiple graduates over the years. He's trained people in his labs who've gone on to careers as nurses, pharmacists, PAs, physicians, PhDs, and has been quite engaged since 2010 at USD Sanford School of Medicine. He has been working through murine models initially through ubiquitin-like proteins, UBXN2A as tumor suppressor agents, and then went on to develop human-derived colon cancer cell lines in translational research. It's been fascinating, employing spheroids and things to actually build behavioral biologic models for tumor cells, things like polyps and behaviors that they might demonstrate. And he's gone on to develop a plant-based compound that they discovered and is involved in translational research, increasing the expression of this tumor suppressor protein, and has been engaged with our residents and students, our graduate students as well over the years. He's participated in organized symposiums over the years and participated quite a bit throughout education throughout USD. So we're happy to have him today. Deepan Punirsavam is our first-year GI fellow. We're proud to have him here today to introduce him and to introduce this topic. So we'll make way for them to get started.
Hey everyone, thanks for being here. My name is Deepan. I'm one of the first year GI fellows here. I did my medicine residency here, and then my med school was back in India. And today we're gonna discuss a little bit about early onset colorectal cancer, which has been a new crisis that's been going on the last few years. And we'll also talk about some novel treatments in the introduction that I have here. Before that, I'm going to touch a little bit on epidemiology of colorectal cancer in general and current incidence and mortality, and then we'll get to the early onset colorectal cancer and the newer treatments that we have. Some of them have approved, and then some of them in trials. So we'll talk about them. So colon cancer is the third most diagnosed cancer in men after prostate and lung, and then in women it's the second most after breast cancer. And when it comes to cancer-related deaths, it's the third most common cause of cancer-related deaths in both men and women. In US, approximately 154,000 cases of large intestine cancer are diagnosed every year, and out of which 47,000 are rectal cancers, and rest of them are in the large intestine. And approximately 53,000 die every year from colorectal cancer in the US. I have an image of the different stages of colorectal cancer, where stage 1 is the mucosa, and stage 2, stage 1 is the submucosa, and stage 2 involving the muscularis layer, and then stage 3 getting a little bit out of the colon up to the serosal layer, and then stage 4 is metastasizing. And talking about incidence, the highest incidence is in the Western countries, in Australia, New Zealand, Europe, and Northern America. And the lowest rates are found in Africa and South Central Asia. And the lower rates in Africa and South Central Asia are attributed a little bit to lower access to colonoscopies and the stigma associated with it, in the background of lesser exposure to dietary and environmental hazards and things like that too. In the US, average lifetime risk of colorectal cancer is 4%, and it's higher in men than women, and higher in Black Americans than white Americans. And over the last few years, we've been seeing a slow shift towards increase in right-sided colon cancer, especially cecal primary, both in US and internationally. And we think the studies think that this is most likely because of colonoscopies getting more and more advanced, and then the technically difficult colons where it's hard to get to the right side up to the cecum in some patients. And then also the right side is not prepped very well in a lot of the cases, and colonoscopy is the best we have, but then it's not 100%. So that kind of attributes a little bit towards increase in right-sided colon cancer incidence. In US, the colorectal cancer rates have been declining by 1.2% every year. And this was the data from 2014 to 2018. But this decline has reduced from it used to be 2% every year. So it was declining by 2% every year. And then over 2014 to 2018, that's been declining by 1.2%. So it's not, it's not an improvement where we're coming down from 2%, declining 2% every year to 1.2% every year. And mortality-wise, in the US and other Western countries, it has been decreasing progressively since 1980s, thanks to the screening modalities and then the newer treatments. And the SEER database shows that the mortality rate per 100,000 under 50 has been slowly decreasing by 2%, and then eventually went up a little bit by 1% in 2018. We don't have data after that yet. And nearly 65% of all patients treated for CRC, all stages, all sites between 2011 and 2017 survived 5 years, which kind of tells us that the treatment modalities that we have now are slowly getting more and more advanced and helping patients with the treatment. And early onset colorectal cancer has been a new health crisis, and it's basically colorectal cancer diagnosed under the age of 50. And I have a picture of Chadwick Boseman here, who was one of the highlight cases that came out a few years ago, where he died of stage 4 colorectal cancer. And he was diagnosed with stage 3 colon cancer when he was 39 years old. And he did not have any family history that I could find. He did not have any significant history of any syndromes or something that required follow-ups, but just had stage 3 colon cancer when he was 39 years old and died 4 years later when he was 43. Incidence is slowly increasing in population under the age of 50, while it has been decreasing above the age of 50 because of the screening modalities that we have, both in US and other Western countries too. And in the US, the incidence under 55 years went from 11% to 20% from 1995 to 2019. Just in a span of 20 years, it has significantly increased. And one of the biggest questions that we have is early onset colorectal cancer a representation of shift in age at diagnosis because we are doing more colonoscopies now, and is it attributed to the early detection? Most likely not, because all these early onset colorectal cancers are diagnosed at a much higher stage. They are diagnosed when they're like stage 3 or stage 4, when they have complications going on, when they have symptoms like obstruction or bleeding, when the tumor has or metastasized to other organs. So it's all higher stage colon cancers when they're diagnosed, which kind of tells us that the process started at least 5 or 10 years earlier than that. So it's not just a shift in the age of diagnosis because of the early detection that we've been doing, but it's more so a health crisis that's happening. The SEER 2017 to 2021 criteria database shows that the age of diagnosis and the rate per 100,000, you can see it steeply going up once patients hit the age of 40 or 35-ish, and then it almost doubles by the time they get to 50s and 55s, and then continues to go up from there. And some of the risk factors when it comes to the early onset colorectal cancers is one of the biggest ones is the hereditary colorectal cancer syndromes, and it's responsible for almost 35% of those. And the hereditary CRC syndromes that we most commonly know are Lynch syndrome, FAP, and those ones are only responsible for 5%, and rest of them are all other different genes that different mutations that happen, and there are multiple genes that have ongoing mutations and that lead to hereditary CRC syndromes, and that's responsible for early onset colorectal cancer. And given this very high proportion of germline mutations, variants, not just one specific gene, but wide variety, genetic counseling is always mandated for these patients, and also testing of the family members too. And some of the potential risk factors that the studies have identified are almost similar to average onset CRC. And they include obesity, metabolic syndrome, metabolic dysfunction associated liver disease, sedentary behavior, meat intake, unhealthy diet patterns, processed food, hypertension, hyperlipidemia are some of the factors that we see in the studies. And the history of CRC in first-degree relative. And some of the other factors listed below have limited data. And one of the biggest one includes IBD and alteration microbiome, CKD, exposure to organic dust, lower level of education, socioeconomic status, excess alcohol consumption, and lack of regular use of NSAIDs was an interesting factor that I came across. We know that NSAIDs and aspirin have been shown to have a little bit of a protective effect in terms of colon cancer. And up until 2016, USPSTF used to recommend aspirin for colon cancer prevention. And even now, aspirin is being used for patients with hereditary syndromes who do not have enough access to get colon cancer screening, or if the polyps are not being eradicated thoroughly in patients with polyposis, aspirin is added for prevention. And it's also added for patients who have had curative surgery and for colon cancer, and also as an adjunct treatment in chemotherapies too. And it basically works by inhibiting cyclooxygenase and then also inducing apoptosis in cancer cells. And that's one of the mechanisms. So lack of regular use of NSAIDs was also found to be a risk factor, but like I said before, the data is very limited. And low vitamin D intake was one of the factors, renal transplantation and acromegaly. And IBD, IBD has been also starting to, we're starting to see more patients who are early and early. There are infantile IBDs in patients younger than 2 years of age. And the earliest colon cancer that I saw related to IBD was a patient who was 5 years old, diagnosed with IBD, ulcerative colitis, had 10 years of ulcerative colitis, and then got diagnosed with colon cancer when he was 15 years old. That was the youngest that I saw. So it's one of the significant risk factors for early onset colorectal cancers. And apart from that, the earliest that I could find were aged 19, 20 from hereditary CRC syndromes, and then patients in the age of 23, 24 for sporadic CRC syndromes. Is early onset CRC genomically different compared to average onset CRC? And it's not significantly genomically different, but the factor is, if you see the curve here, this kind of tells us the epigenetic drift, where with the drift and the telomere shortening, it's the normal aging where the decline in stem cell function and immunosenescence happens, and that's the line in the middle. And then the line below is healthy aging, and then that's due to the lifestyle and longevity genes and all that. And the line above is the epigenetic drift, where the DNA methylome is deregulated, and that happens to happen faster in patients with early onset CRC. So it's basically the same genomic drivers for methylation, but then it's happening faster, which kind of tells us that the mucosa in patients with early onset CRC is aging faster than their chronological age. And that leads to early onset CRC is what one study found, whereas other studies also tried to look at that and did not have the similar results, but one study found that it's due to the epigenetic drift. And the current treatment for CRC includes mostly fluoropyrimidines, and those ones work by damaging the DNA and their pyrimidine components, and they integrate into the DNA and then damage it and help with the treatment. And platinum-based drugs kind of unlink the DNA and cause DNA damage and induce cell apoptosis. And then the topoisomerase inhibitors unwinds the DNA and doesn't let the DNA to be reintegrated. So it also helps in DNA damage and induce cell apoptosis. So those are the drugs that we most commonly use, have been in the use right now. And we have some newer therapies where we're working on VEGF, EGFR, and VEGFR receptors. And by blocking those, it kind of stops the downstream kinase pathways and then also the mTOR pathways, and then eventually decreases cell growth and prevents cell migration and improves survival and things like that. And these are the drugs that have been currently approved, and all of those are most likely used in advanced metastatic colorectal cancer situations. And then the treatment also, one of the things that once the patient has colon cancer diagnosis, look into the genes and mismatch repair and things like that. And it's good to know what the mutation is, because if someone has a KRAS mutation that's an activating mutation, that's way down in the pathway, so you will not be using any drug that's affecting the factors that are higher up in the pathway. So it's important to know which genes they're affecting. And this is the basic pathogenesis for the for colon cancer incidence, and how the normal colonic epithelium via two different pathways, the microsatellite instability pathway, and then the CAMP pathway, and then the conventional pathway through different genes. And one thing that is important is the serrated pathways through the BRAF gene, and that happens in patients with sessile serrated polyposis syndromes, which and sessile polyps are kind of hard to identify, and they're mostly happen on the right side of the colon, which was also one of the factors why we are seeing more right-sided colon cancers now, and BRAF mutation is being targeted in those cancers. And aspirin NSAIDs actually work by affecting the APC, or the Wnt signaling pathway, and that also involves the beta-catenin too. And that's the pathway where the aspirin NSAIDs kind of affect by blocking cyclooxygenase and also apoptosis. And these are the newer drugs that are under trial. There are so many others too, but then these were the ones that kind of caught my eye and had some data on them. And KRAS G12C is a specific mutation inhibitor. It's newly approved in Jan 2025. And BRAF targeted therapies for the BRAF V600E mutated CRC, and that's the serrated pathway colon cancer. And the dostarlimab had 100% clinic response rate in patients with rectal cancer. And then it got a special breakthrough treatment designation from the FDA recently because of the 100% clinical success in phase 2 trials, and is going further. And then the ELI-002 is a vaccine that's targeting the KRAS, and it's also in phase 2. And the CAR NK cells is similar to CAR T cell therapy. It's the chimeric antigen receptor engineered NK cells, and they're in preclinical phase where the NK cells, the natural killer cells, are engineered to attack the cancer cells and prevent damage to the healthier cells. And nanomedicine is also improving, and we have preclinical studies on them. It's involving magnetic nanoparticles that deliver to the areas based on the hyperthermia, and it targets the hyperthermia regions through in cancers that has like particular genetic pathway. And ruthenium components, one is bold 100, it's in preclinical and early phase. And then we also have epigenetic modulators that are used in combination with immunotherapies too, and those are also in preclinical and early phase. And then we also have other drugs too, and we'll have Dr. Zwani talk about them here in a little bit. But yeah, so the take-home points from my presentation portion would be just not early onset colorectal cancer is a real crisis that's going on. So be aware of your patients, bowel symptoms, alternating bowel movements, and change in stool caliber, blood in stools, and weight loss and things like that cannot be taken easily. And we also still haven't identified specific risk factors to incorporate it into screening modalities yet. So we cannot use those to say if this patient needs screening or not, but then just be aware of symptoms and things like that going forward. All right, I will pass on to Dr. Rasmani here. Thank you.
All right. Hi, everybody. I would like to first thanks Dr. Berson for inviting me and giving me this opportunity to talk with all of you here. Is really my pleasure to share some of my works with you today. And thanks for the introduction. And I want to thanks Dr. Panir Westman for last 6 months. We have a back and forth work, and I really looking forward for more collaboration in the future based on the research I have. So in my slides, I try to summarize basically 16 years of work in my lab when I joined USD in 2010. Basically, we focus on colorectal cancer, and the reason for that, as I said, that Dr. Panir made my job easy for the highlighting the challenge that these days we have with the colorectal cancer. So I'm focusing on a little bit basic science, and then I go to the more translational project that is ongoing project in my lab. So it was quite serendipity that around 17 years ago, I was working on proteins that involved in the uniprotein pathway. And these proteins basically control the protein quality control in the cells. And I was at Baylor College of Medicine in Houston, and I'm basically trying to find which type of this protein important for the brain. And as I said, as a serendipity, there was a paper that published at that time in 2009. And particularly, they said that this protein elevated significantly in colorectal cancer and breast cancer. And it wasn't just a random increase, it's just the elevation was hugely significant. And so I asked this question, what is the role of this protein in the colorectal cancer? I look at the survival rate of the high expression and low expression of this protein in the colorectal cancer. I saw that basically patients with higher expression of this protein, actually they have a better survival. So this was exciting, and I started work with the Stanford, and luckily with help of Dr. Douglas Lynch, we access to the tissue, and we look at the different stage of the colorectal cancer, looking at the level of the and as you can see, we found that while in the early stage of the colorectal cancer, UBX goes up, but later it goes down. That is the typical behavior of the tumor suppressor proteins, that they try to fight back against cancer at the earliest stage, and then when everything is mutated as and then they give up. So, as I said that I tried to summarize, I just want to draw your attention to the effectiveness of these proteins. So we make an inducible cell line, and then we induce with the doxycycline. And as you can see here, the tumor is almost half size of the other side that doesn't have the expression of UBX1. So definitely the expression of UBX1 decrease the tumor size. So long story short, 2014, the first paper released, and we found that UBX1 basically reactivate another important tumor suppressor protein, which is p53. And we were very excited, and it's accepted in the Nature Associated Journal, because the p53 at the earliest stage of the colorectal cancer stayed as a wild type. It mutated later in the higher stage. So there is a hope to reactivate the p53. And I will not go to the detailed mechanisms, but that was one of the pathways we discovered. But I show you the xenograft model. I decided to go to the more physiological model, and we basically generate a lung cancer model, that this mouse model with a carcinogenic agent developed tumor in the descending colon and rectum. And here the result is very interesting. This is the number of the adenoma developed in the wild, and this is the number of the low and high grade adenoma in the mouse that has less UBX1. This is exactly what we see and more cell proliferation. So less UBX1, more adenoma, especially high grade adenoma that is ready to move to the pathology of the adenocarcinoma. So we further were able to finish the study and find out that the protein that activates the p53 in the early stage of colorectal cancer, while this protein UBX1 completely invaded, and that is resulting of the less tumor growth and less tumor invasion. from the beginning, we found some data that indicating that the function of the UBXN2A is more than the p53. And here, there, this is the green represent the tumors migration when UBXN2A overexpress. And then we even added more enhancing of UBXN2A, even the migration is increased. And that is basically pushed me to the second hypothesis around 2016 that maybe UBXN2A has a dual function. Not only target primary tumors and by increasing p53 tumor suppressor protein, somehow slow down the tumor migration. Having that one, we had a very difficult job. There are many pathways involved in metastasis of the colon tumor to liver and lung. And thanks God, we have an inducible system that we were able to use it after UBXN2A and see what happened to this. Among all these pathways, we saw a significant inhibition of the PI3-AKT, which is you just mentioned in the traditional, conventional pathway mutation that PI3K is one of the gene that is affected as early as earliest stage of the tumor. So this was exciting. And why? Because this is part of the mTOR pathway, which is the mammalian target of rapamycin. The mTOR has got two pathways. mTOR1 that is more in the metabolism, mTOR2 as you can see more in the migration overexpress UBXN2 in cells, and surprisingly, we saw a significant decrease of the phosphorylation of AKT, which is in the downstream of PI3-AKT. That's indicating that the UBXN2A is basically target the AKT as a dominant. And but the finding was even much better when we found that there is no effect on mTOR1. And I said that much better because most of the drug in the clinical trial that they went to the clinical trial, they were mTOR1 inhibitor or mTOR1, mTOR2 inhibitor. And the side effect of the mTOR1 inhibitor, because I said that the metabolism, it cannot be sorted out. And all those clinical trials were due to this mTOR1 inhibition. So we felt that we have a mTOR2 inhibitor. And basically, when we did the experiments, we found that the UBXN2A particularly targeted subunit in the mTOR2 pathway that causes the AKT pathway goes down and the downstream goes down. So it's a selective targeted therapy that can be considered by elevation of UBXN2A and targeting the victors. So I just put this slide is too much biology, but I just wanted to draw your attention by elevation of UBXN2A. Look at the turnover and half-life of the protein. Basically, significantly goes down. And we are basically convinced that UBXN2A targets the Richter proteins, and as a result, the AKT pathway mTOR1 is decreased. The migration invasion, everything is downstream target of the AKT pathway goes down. So we believe that we have a protein that, as a tumor suppressor protein, has a dual function by elevation of another tumor suppressor protein, which is p53, as well as is also go for another oncoprotein to basically have a more efficient effect on the drug. So 2017, 2018, I found that everything need to be translational. The NIH started to change the fashion. And as a result, I had to find a molecule that increased pharmacologically UBXN2A, we did a high throughput drug screen. And I remember that evening that I received a 12 candidate out of 1,800 drugs. And when I look at the molecule, Vorapridine was the second one in the list. The first one was a little bit toxic, but the second one caused me to jump on my chair because when I searched for the molecule, I found that in long time ago, 1960 to 1970, Vorapridine used as an antihypertensive supplement in human. So it was used in the human in the past. So I said that instead of 20 years dealing with the FDA, maybe it's 10 years dealing with the FDA. So you can see Vorapridine increase UBXN2A and induce the apoptosis. So everything very happy. So I went forward and look at how the Vorapridine as a plant extract caused elevation of UBXN2A. We found that very interestingly increase the RNA level of the UBXN2A and protein level. So it's really is a solid, potent inducer of UBXN2A. So that's good. And here I summarize a xenograph study again to show you that how effective Vorapridine in basically inhibit the tumor growth. So it's a female, male, and here is the control treated with 0.1% ethanol, and here is Vorapridine. And you can, we have now cell line that they have the fluorescent tag, so we can check the progress of the tumor in the live animal. And you can see here, and the sizes that is we see the control and Vorapridine. Basically, we saw a significant reduction of the tumor size in both male and female. But interestingly, I combine this data, but it's the male mice responds to the Vorapridine much better than the female. And we started to see from this initial study that there is a sex differences between male and female in response to the Vorapridine. So again, I decided to go back and do more, having a more physiological model. So we use the AOM model. So we inject the AOM DSS. And the DSS that we use, as Dr. Paris-Servan mentioned, that it induces some inflammation. So this model is kind of between the IBD and colorectal cancer. And then we treat with the ethanol. And I wanted to draw your attention to this study that we were very excited. These are, again, we use the ultrasound to visualize the tumor in the live animal. So these are the live animal, and this is after the termination. And what we notice, this is obvious that, as you can see with BTD, the development of the tumor in the descending colon and rectum is significantly less than the mice treated with just ethanol. And these are basically the tumors that develop at the termination. More interestingly, when we treated mice that has low UBXN2A, we saw also a response, not as good as the wild type, but still good. And I wanted to highlight this green column here. These represent those patients that they have lower UBXN2A, and if we can increase UBXN2A, we can improve the survival, as you can see here. So when they have half expression of UBXN2A and we use Vorapridine and we basically boost the UBXN2A dose up, we were able to a little bit improve compared to the number of the tumors that we see in the wild type treated with just ethanol. Okay, so everything translational. I was very lucky that I started a collaboration with Dr. Biliker and Dr. Turahi. This is started exactly before COVID started. And what I said as a lucky, because with his contribution and the guideline by Dr. Biliker, he started to access to the tumor that is collected in the sample. So what will happen that basically when they have a patient with colorectal cancer and if the patient allow to use the sample for the science, the pathology department, they use part of that they want, and the rest they call me immediately and they said that, do you want fresh and frozen? Sometimes I have time and everything is ready. I said fresh, and in 24 hours I am here to get the tumor in the median. And we take it to the median, and then we make a primary cell line. Basically this from the tumor. The success rate was not good at the beginning, but now we are moving to the 60% of the tumor can be primary. And then we make a 3D structure that is more physiological and acceptable by the NIH and FDA. And just I wanted to draw your attention here. When we treat this patient, one and patient two with brachytherapy, look at the amount of the erythroid out of the NM2. And we also saw a decrease in the VEGF, which is one of the target of the targeted therapy. So we didn't stop on this. We developed making a type of the 3D structure that mimic the polyp in the colon. And the reason for that, this is almost last 1 year that we started this project, because I'm sure you heard that the FDA have already changed the rules for the preclinical model. It's not anymore 2 species, 2 animals. They accept 1 animal and 1 organoid system, 3D. Of course, I had to shift the resources to this type, and this is not a cheap technique. It's a very expensive way to make this type of 3D structure. What you see is the top of this mushroom that is basically stabilized on a matrix. So we have this mushroom in a 96-well plate, and I'm really happy that Dr. Anisman mentioned about the drugs, because we use the PyFUs, which is one of the early choice of drug for the colorectal cancer. This picture is obvious, I hope, to you that if you look at the DMSO, the treatment with control, look at the number of cells. It's basically exploded. But look at the cells, basically it's just a necrotic part. And PyFU, as we expected, also does the same thing. So it looks that the brachytherapy is as good as PyFU to basically generate necrosis in the cells and stop the growing the cells. Okay, so I'm going to go to the last part of my talk. Like every small molecule, brachytherapy has got an issue, and the issue is that the plant alkaloid and unfortunately binds to the sodium channel. So brachytherapy that reach to the brain, it can make neurotoxicity. And that's the reason that in 1970, they pushed back the brachytherapy as a hypertension supplement because they saw neurotoxicity. However, the amount of brachytherapy that we use is much less than the amount that they use in human for the anti-hypertension. But this is it. And honestly, I became an easy target for the reviewer of NIH. They just searched neurotoxicity. No, it's bad. Go away. So I started collaboration with the chemist, Dr. Saeda, in the chemistry department. We decided to package the brachytherapy into a nanoparticle. The nanoparticle is 100 micrometer, and it cannot pass any more blood-brain barrier. So that is check. And what we do further, we coated with a casein, a protein, that these casein can digest on the tumor and not normal cell. I cannot go to the details, but tumor cells, to make the space around themselves to grow, they have to release digestive enzyme. And one of those is MMP7 and MMP9. Our nanoparticle close to this tumor digested the casein and release its carbon. So it's a kind of this release enriched drug next to the tumor while normal cell even is fine. And we have a charge on nanoparticle, so it binds to the charged negative cancer cell, but it doesn't have any affinity to normal epithelial fibroblast colon cells. So that was good. But as we mentioned, that the problem with the colorectal cancer is a metastatic one that is decreased significantly survival, and we don't have still a good choice for the treatment. What happened, tumor is in the liver, and so we generate a liver cancer model by injecting the cancer cell to the spleen. So it's mimic kind of a metastatic way to reach to the liver. So we generate the tumor in the liver, and then we tag the drug, the nanoparticle, and inject it. So where is the nanoparticle end up? In the right zip code, in the liver. It didn't go somewhere else. Basically, the liver filter all the nanoparticles, and we wanted actually filter it because now it's in the right place. And look at this tumor and this green nanoparticle that is completely around that one. And if this is bile duct, basically after that, it just go and get out of the systematic body. And interestingly, we don't see a lot of link with the spleen. Another evidence that really the particle end up on liver. And I just wanted to share that one with you. We make the liver model, and then we treat it with nanoparticle. This is male and female, and look at the liver. Basically, it's exploded by the tumor. And when we treat it with MPBD, it's still a lot of the liver side is intact, but we have some. Again, what we found is that the male mice responds much better to the NPVT than female. It shows a trend to decrease, but it wasn't significant. So this is a remaining question for us, that what happened to the female in the liver that is metabolized probably differently with a different speed, gradually that it has a different. So long story short, this is 16 years of my work. So we found a molecule that if we package it in a nanoparticle, we can precisely target cancer cell while leave the normal cell intact. Release of this carbohydrate next to the cancer cell release the UBXN2A, the tumor suppressor protein, but with dual function, targeting p53 and activating the p53 for apoptosis in primary tumor, but also targeting the mTOR2 pathway that is more in the tumor metastasis. So we think that Buratidine either alone with this nanoparticle technology or in the combination can be a potential platform for the new anti-metastatic drug. I finished all the preclinical data for the mice. We are in the preparation for the pre-IND for the FDA. I'm trying to finish all the organoids work, and hopefully in the next 2 years, if everything goes finger crossed okay, we want to try the first small clinical trial. And I was very lucky when I talked with Dr. Budiker. He said that he doesn't have any issue if this is can happen in the sample in the future. Okay, so that is my group, postdoc, undergraduate, PhD student. These are sources of funding that I have. These are collaborators that they helped me in the last 16 years. And as I said, that Dr. Tulaki is a very key point in this. When they see a mission in the grant, and they look at you differently. Thank you for your listening. Any questions?
Dr. Rizvani, this is fascinating.
Thank you so much.
So I have two questions for you, and I realize you're not a soothsayer, but you compared to 5FU, you showed that you could get necrosis of the cells. In your thoughts, can you give us any kind of a projection based on treatment like this? The kind of results, and obviously this is all theory, but you're going to have to hypothesize when you go to clinical trials. What kind of improvement in survival are you anticipating? And my second question is, how do you plan to deliver this product with the drug in human trials?
Okay. The first question it would be, again, kind of precision therapy. We know that only 50% of patients with the colorectal cancer, they have lower level of UBXN2A. 50% they have normal. So theoretically or tactically, that is will go when we have the biopsy of the tumor and we determine the level of the UBXN2A in the extracted tumor.
And almost males, right? Because you're seeing such a more profound effect
Exactly.
than female.
Exactly. And then when we saw that it is lower, then broadband can be an option for these patients.
Metastatic disease.
Metastatic disease with lower UBXN2A. The second question.
Delivery.
So for the nanoparticle that we use is a silica, basically is digested immediately in the liver. And we knew at the beginning that we need to follow exactly the routes that it is human. We injected the nanoparticle IV to the mice. Yeah. And basically, we have a very good PK/PD study that shows that it's significantly increased in the liver, but is not even traceable in the brain, lung, kidney, and other tissues. So it's already a clinical trial that shows that nanoparticle with this certain size that we make is end up in the liver, not anywhere else. And that because the liver function as a filter and catch everything. In my case, it's lucky for my research that in colorectal cancer and metastatic, it started from liver, and then usually lung is the second. But for some nanoparticle, it's very difficult to guide them to the right place. We're talking about breast cancer or lung cancer. But in this case, as I show you, that is enriched in the liver, in the right zip code. Thanks for the question.
Thank you. It's exciting.
Have you developed any hormonal controls for your mouse models that demonstrate sex differences between the expression of the proteins?
I really love to do that. And I started to talk with people that they are in this area. Is another school. But I'm trying to connect to some collaborators that they are interested in the sex and basically bring that one. And I know that even the IBD rate in the male and female is the difference. So it's a very multi-branching thing. I know that how much the microbiome is affect the drugs and etc. But yeah, it's a good question. It could be the hormones and the sex differences change the metabolism of the broadband in the liver. Yeah. Okay, thank you so much for.
Thank you for your time. Appreciate it.